Hello guys, good evening. So welcome you all to the ninth class of Basics of Cardiac Pharmacology. And I hope you all are doing well. I hope your exams are going on and you are getting a little time to come and join the classes. So today is the ninth class and I hope this is my last class because next we are calling the specialists or external experts for all for next three classes, and I may not take your classes further. So that would be my last class, hopefully. And that's a great news as well because now we are planning for the advanced version of cardiac pharmacology. So definitely, this journey is not ending here. Of course, there are three more classes, and we are getting experts from outside to continue this course. And so, without wasting time, I think we are live on YouTube as well. So we should start the class. Okay, guys. And one important information I forgot to ask you. Did you guys do your assignment? Everyone? If not, please do it. It is still open. It will be open for 2 weeks now. So whenever you get time, you do it. Last assignment also almost half only did. So I'm requesting everyone, you have registered to the course, all 10,000 plus students. I'm requesting everyone to watch the classes or this exams you have to take, all the assessments, both the assessments, and with the assessments you have to take the final exams as well, right? So be prepared and give your exams, attempt your exam. It is just a 10-minute work, not more than 10 minutes, I'm very sure. There are only 20 questions which you have read in your last classes, and which we have discussed in your last 5 classes. I think assessment 2 is related to hypertension only. Okay, so better you just open that link and fill your form and do your assignment complete. Now let's open the slides. Let me join. I hope slides are visible to all of you. Uh, can someone share the link in all the groups? Okay. So yeah. So guys, good news is here. The another good news here is that International Symposium on Medication Therapy Management, ISMTM 2020. It was scheduled for 19th and 20th December 2020. But now, due to your exams, due to the universities who has suddenly scheduled their exams for PharmDs, for B Pharms, and for pharmacy students, we have rescheduled the conference, and now this conference is going to conduct on 2nd and 3rd January 2021. Okay, because when we are conducting the conference and students are only not participating, then what's the use, what's the benefit? So this is for the students, and there are many things for the students to get benefited, like to get their research presented in the conference. They can present their cases, special clinical cases or any clinical case they can submit, and if it is accepted, they will get a chance to present. They are getting a chance now to present their any kind of research, epidemiological research or specific MTM research. If you have something specific, if you are good in video making and all, there is another category for you, that is 3 minutes video preparation, right? So prepare your video and submit to us. If it is good, then you will get a chance to present the same video in we will display your video in our conference, right? So everyone will get a chance, everyone, don't worry. So you can submit your abstracts, clinical cases, any research, any MTM related research. If you are associated with the any kind of digital editing and all, you can submit your videos, right? So and it will be in the your research will be presented in the poster forms, oral forms. So you have variety of presentations, variety of activities in this symposium, and you will get a chance to do that, right? And along with that, we are conducting we are conducting many things, many other things like MTM talks and oral and poster presentations, as I was telling you, and then MTM quizzes. Like there'll be two quizzes on day 1 and day 2. So the winners will get a good price. Winners, we are decided to give very good prices. So I will just give you a hint. You will get kind of 5,000 rupees voucher to cash on in the upcoming courses of CLIMAT, or you may get 3 months or 6-month internship. So it is a best chance, guys, for the top 10 winners to do it, to get a really cool prize, right? So now the new abstract submission dates are revised, and new case submission or abstract submission date is 15th December 2020, and you will get the acceptance notification by 20th December. And you can register to this conference by 15th of December 2020. So these are the revised dates for January 2nd and 3rd conference. And what are the highlights? And see, these are our collaborators. We are, our organizers are India's most famous pharmacy association, that is Indian Pharmaceutical Association, IPA, and then we have Association of Community Pharmacists of India, ACPI, and then we have WYHF with us, World Youth Heart Federation. That is again a big organization of youths, and who are working in the cardiovascular conditions, or who are working in the field of cardiovascular diseases, right? So and you can see our partnering institute, which are increasing daily. So these are just old 12 institutes, but now we have almost 20 plus partnering institutes, and 5+ digital partners, including many societies. So guys, don't miss a chance. It is an international symposium. You will get it is similar to IPC conferences, and you will get a feel of international symposium event. This medical management therapy, this MTM, is very new trend in India, and we are going to establish this in India, because you should know about the medication therapy management. It's very important for pharmacies, for B farms, or for the pharmacy professionals, right? And for the medical professionals and nursing professionals as well, because they on the daily basis, they're going through with the lot of cases, with the lot of complexities, with lot of with many things in their daily practices. So they have to take care of these things. So yep, I think yeah, now we should start our course class, and that class is today on my very favorite topic, on my topic of my PhD, we can say, and it is my specialization. So let's dig the topic of heart failure, and I hope you will come up with a lot of questions, and you will clarify all the questions to me on heart failure, if you get between the class, or if you get after the class, or if you have before initially, like right now in your mind, you can note down, and you can keep in the chat box. We will definitely discuss all the questions today. Okay, and this class is going to be a little long, because that's my favorite topic, and I will try to cover each and every simple and basic point. So let's start. Today we are going to talk about heart failure basics. One sec, let me make it full screen. Yeah, yes. So first question which comes in our mind is, what is heart failure? What is the definition of heart failure exactly? So according to, there are three major organizations which are looking after the cardiovascular diseases, all the cardiovascular diseases. They are making guidelines, they are defining them, they are defining their clinical characteristics, they are conducting all the trials, they are uh, giving full glance on the cardiovascular problems, each and every cardiovascular problems. And these three associations or organizations are American College of Cardiology, ACC, American Heart Association, AHA, and then European Society of Cardiology. And worldwide, these three guidelines or these three organizations are the main organizations everyone follow. Around the globe, they follow the ESC guidelines. Around the globe, they follow the ACC and AHA guidelines. And ACC and AHA and ESC, these are the main organizations which actually fix the guidelines based on the evidence-based medicine, based on the evidence-based medicine or based on the clinician's practice, right? So these are the major organizations. So what is the heart failure according to AHA and ACC, American College of Cardiology and American Heart Association? Am I audible, guys, properly?
Yes, sir.
Okay. So heart failure is a complex clinical syndrome. Why it is complex? Because it includes structural and functional, both. It includes structural and functional impairments or functional, disability or functional, or we can say the dysfunctions, structural dysfunctions or functional dysfunctions of ventricular filling or ejection of the blood. What is ventricular filling? Ventricular filling is when the blood from your left atrium comes to your left ventricle, right? Or from right atrium to right ventricle. But majorly, when it comes to the heart failure, we always count the left side. We always count the left system, right? So from the left atrium to left ventricle when it comes, or when it goes out, when the left ventricle eject the blood, ejection of the blood, when the left ventricle eject the blood to the aorta, and then from the aorta it will go to your whole body parts, all the body parts, right? So when something happens with your left ventricular, right, guys? It can happen with any ventricular, any ventricle, maybe right ventricle or left ventricle, but majorly, if it is happening with right ventricle, then we call it right ventricle failure, right? Or when it happens with the left ventricle, then we call it left heart failure or right heart failure. It depends on, but majorly 80% or more than 80% cases are with left heart failure or left system failure, right? So why it is complex? Because it includes structural changes or a kind of structural impairments or functional impairments, right, in the left ventricle, which affect actually the ventricular filling or ejection of the blood, right? So this definition was given by ACC and AHA. Now European Society of Cardiology has elaborated this definition of heart failure. They have elaborated, okay, they made it broad. So they included all the symptoms, signs, and what is exactly the heart failure, right? So heart failure, according to them, is a clinical syndrome characterized by typical symptoms. Every heart failure patient will one of these symptoms. Maybe it is breathlessness, ankle swelling. Ankle swelling is what? It is also called as pedal edema, and then fatigue. Okay, guys. Breathlessness, ankle swelling, fatigue. These are the typical symptoms of heart failure. Then it may be accompanied by signs. What are the signs of heart failure? Elevated jugular vein pressure. Jugular vein pressure is what? See, if you see here on this side, this vein. See, this vein is called you can follow my finger. This vein is called as jugular vein, right? So pressure of the blood, it raise the vein. This vein will come out. This vein will come out, and you can see, it will be visible much more. So it will be visible, and that pressure can be measured by the elevation of this vein, by the elevation of this vein. Now it is normal, it is inside the skin, and you can just see the traces of the vein. But when you have the heart failure, this vein will come out due to the pressure, and you can measure the elevation of the vein, and based on that you can find the pressure, find the venous pressure. So that is called jugular venous pressure. So it will be elevated in that case. So we usually measure that in centimeters, like how much it is raised, how much it is coming out, like 1 centimeter, 2 centimeter, 3 centimeter, or 4 centimeter. So based on that, they have the scaling system. They have the scaling system, like how much it is, and based on the scaling system, we give it the severity. Like if it is less than 2 centimeter, it will be mild, or once less than 2 to 3 centimeter, it will be moderate. Then more than 3 centimeter, it will be severe. It will be severe heart failure. If your vein is exactly visible, or it is elevated, so in that case, your heart failure severity will be calculated. Correct. Then then the second sign of heart failure is pulmonary crackles. What is pulmonary crackles? You know, when you must have seen the babies. I'm just giving an example, but it happens in the heart failure. You must have seen the babies when they get pneumonia, or any adult also when they get pneumonia. You know, they when they breathe, na, that time you will feel something is breaking inside your lungs. You know, the break is like a glass breaking sound. You know, the cracking sound. So that cracking sound is actually called pulmonary crackles. So, you know, so in the heart failure, with each breath you will feel that pulmonary crackle sound, and you can, you know, listen it with the stethoscope. So that is another the typical sign of heart failure. Along with that, peripheral edema. Peripheral edema is what? Peripheral edema is nothing but swelling of your limbs. Swelling of your limbs below the knees. Your calf or your you know, legs will be swollen in that case in heart failure. Why? Because there will be fluid overload and kidney will not be sufficiently you know, eliminating the fluid from the body in that case. Because pumping system is less, or maybe your, you know, ventricular filling or ejection of blood is decreased, the output is decreased. So in that case, what happens? There will be fluid accumulation in the body, or majorly in the legs. So it will cause the swelling, and that swelling is called peripheral edema. So there are again, guys, there are two types of peripheral edema. One is non-pitting, one is pitting. Okay, P-I-T-T-I-N-G, pitting edema and non-pitting edema, normal edema. So normal edema will be, there will be swelling on your leg, but when you press with the finger, that swelling, it's like a swelling here. If you're pressing with that, with your finger or with something, it is not going in. But in the pitting edema, when you push that swelling, it will go inside, and it will you know, make a pit kind of thing, or make a little hole, or make a little, you know, it will come again, it will come out again, it will definitely come to the normal again. But when you press it, it will be there for the seconds, it will be there for the 20 to 30 seconds or maybe more. So that kind of you know, that is the pitting edema. There are two types of edema. One is non-pitting edema, one is pitting edema. So it depends, you know, based on the heart failure also, but majorly it will be pitting edema in case of heart failure, right? Okay. Then now they in the definition they have described all the typical symptoms, all the signs. Now, what is the why it is happening? What is the cause? Caused by a structural or a functional cardiac abnormality, as we have discussed in ACC and AHA guidelines, right? Then what will be the result? What it is causing exactly? It is resulting in a reduced cardiac output and elevated intracardiac pressure at rest or during stress. So that means when your body has the you know, has the fluid overload, it will reduce your cardiac out. Because of cardiac output, reduced cardiac output, it will increase or elevate the you know, intracardiac pressure inside the heart. It will raise the pressure, and it can be seen at the rest or during the stress as well. So this is defined by European Society of Cardiology. I hope you understand this. Heart failure is nothing but it is a clinical syndrome characterized by the typical symptoms and accompanied by signs caused by structural and functional cardiac abnormalities, and resulting into the reduced cardiac output and elevated intracardiac pressures at rest or during stress. Okay, guys. So I hope you understand this definition. It is very easy, and based on that only we will describe all the whole heart failure today. Okay. So next. Now, what are the structural changes actually? Here you have to give a little attention. Structural differences between normal function, systolic dysfunction, and diastolic dysfunction. So, systolic dysfunction is what and diastolic dysfunction is what? Systolic dysfunction is when your blood comes in to the ventricles, right? When your blood comes into the ventricles. And diastolic is when your blood goes out from the ventricles, right? So systolic means your ventricles are filling. Diastolic means your the blood is going out of ventricles, correct? So how? In the normal cases, as you can see here, as you can see here, this is left atrium, this is left ventricle, this is right atrium, this is right ventricle. So blood is coming normally from the right atrium to right ventricle and from left atrium to left ventricle after a whole process. Okay, it is showing the whole process right now. Correct. So what happens in the diastole, in the normal functions, what happens? The ventricle pumps out about 60% of the blood. Amount of the blood, guys, listen here, the difference. In normal cases, there will be enough amount of the blood in the ventricles. They will get the enough amount of the blood and they will eject the enough amount of the blood to the body. And normally they eject about 60% of the blood. Right, got it. But in systolic dysfunctions, what happens? In systolic dysfunctions, the ventricles are enlarged with the blood. Ventricles are enlarged with the blood. Enlarged means now they got the size more. Their size is increased. Ventricle size is increased than normal. Ventricles size is increased than normal. In that case, what will happen? The blood will be there. Sufficient blood will be there in the ventricles, right? In the left ventricle, basically, in the left ventricle, sufficient blood will be there. But due to the high volume, due to the larger volume, the blood pump will, the pumping capacity of the heart, pumping capacity of your ventricles will slow down. It will come down. It will decrease. So it will decrease. So your and the pumping, pumping of the blood, the amount of the blood pumping will be less than 40 to 50% only. Pumping will be less than 40 to 50% of the blood. That's all. In the normal cases, it was about 60%, right? So in systolic dysfunctions, ventricles are normal or enlarged, but ventricles are not able to pump out the normal amount of the blood. Whatever is required, the required amount of blood is not going out, is not ejected by the left ventricle or right ventricle to the wherever it is going, right? Now in diastolic dysfunction, what happens? In diastolic dysfunction, it happens totally ulta. Your ventricle fill, when in that case your ventricles will fill less, or there will be less amount of blood, lesser amount of blood. In the previous case, systolic, blood amount was more or normal, whatever is required is sufficient, right? But in diastolic phase, what happens? The amount of blood will be less than usual. Why it is? Because in diastolic dysfunctions, due to cardiomegaly or due to some other functions, the wall of ventricles will be thickened. In that case, the wall of ventricles will be thickened, right? As you can see here in this here, if you follow my cursor, one sec. If you follow my cursor here, the wall here, you can see it is thickened, right? Here if you see the wall, it is normal. Here also it is normal wall of the ventricle, wall of the heart. But in diastolic dysfunctions, wall of the heart or wall of the left ventricle or right ventricle, wall of the ventricles will be more, will be increased or will be thickened, right? So what happens when wall thickened, when wall, the wall of left ventricle or right ventricle thickened, the size of ventricles will reduce. Size of ventricles will reduce and they will be able to receive only lesser amount of the blood than usual. Correct. When the size will be reduced, then the volume of the blood received will be reduced. When there is less blood, then what will happen? If the function is normal, if the function is normal and heart is pumping about 60%, correct, but the amount of blood which is going out is less, right? Got it, guys? In that case, the amount of the blood will be less, ejection fraction will be normal, pumping capacity will be normal, heart will be ejecting around about 60%, which is there in the normal as well, but the amount of blood will be lower than normal. Got it? In systolic dysfunctions, the amount of blood will be less. Why? Because there is a larger pressure, there is a larger pressure, and the volume is sufficient, but the capacity, the pumping capacity of heart is decreased. Here diastolic pumping capacity of heart is normal, but due to less amount or less volume in the ventricular, ventricles, less amount of blood is going out. Correct in that case. So I hope you understand. In both cases, the blood amount will be less only, but there are two different functions. Here it is due to the less amount received, or due to the less volume received, and in previous one due to the pumping capacity, reduced pumping capacity in systolic. Okay guys, so I hope I'm clear here. Now, so based on the heart failure ejection fraction, based on the ejection fraction, or based on the pumping capacity, we classify the heart failure into three categories, into three classes. Not we, it is given by the European Society of Cardiology. Previously, heart failure based on the ejection fraction was divided into two categories. One is heart failure with reduced ejection fraction, and one was heart failure with preserved ejection fraction. Correct. But now, due to some reasons, because okay, I'll tell you the ejection fraction levels first. Ejection fraction in with reduced ejection fraction heart failure, it will be less than 40%. That means the heart is pumping only less than 40% of the blood to the body, right? And then heart failure with mid-range ejection fraction is when heart is pumping, the pumping capacity is 40 to 49%, right? In heart failure with preserved ejection fraction, the ejection fraction will be normal, okay, more than 50%, more than or equal to 50%. Got it, guys? So now what happened? Previously, there was only two categories. One is heart failure with reduced ejection fraction, that was less than 50%. And one was heart failure with preserved ejection fraction, then ejection fraction was more than 50%. But now for a longer time, there was a debate, like in some cardiovascular problems, like in MI problems, or due to some maybe drugs, or due to some other problems, this ejection fraction comes down. That is not exactly heart failure, but that is due to the certain problems, or due to the comorbidities for a short period. So, and it will not come down too much. It will not be much. It will not be creating much problems. So they pointed it into a gray area. They described the new gray area or new classification of heart failure, that is heart failure with mid range means less than 50, more than 40. So that category is mid-range ejection fraction. In that category, I'll tell you how to define these criteria. First, heart failure with reduced ejection fraction less than 40%. In that case, you need not to go for the specific cases, because your ejection fraction is less than 40 in your echocardiogram, and the patient has severe symptoms or moderate symptoms, and patient has signs. So defining the signs and symptoms, I'm telling you how to define and how to do that. So typical symptoms are major symptoms, and other all symptoms are minor symptoms, right? Other all symptoms are minor symptoms for heart failure. So I'll count. I don't think it's there in the slides. Major symptoms are, as we can see here in the first slide only, first definition only: breathlessness, ankle swelling means edema, and then fatigue. Signs are elevated jugular vein pressure, pulmonary crackles, and peripheral edema. These three are the major symptoms and signs, right? Now, minor symptoms. Minor symptoms are there, of course. So that would be paroxysmal nocturnal dyspnea, PND, right? PND is what? Paroxysmal nocturnal dyspnea. So that happens, this dyspnea or breathlessness occurs usually in the night, in the morning time, morning 3 o'clock, morning 4 o'clock. So that is called paroxysmal nocturnal dyspnea, right? And then there is something called oliguria, or when your urine output is less, or anuria, when your urine output is completely gone, there is no urine output, right? And in that case, there are other more there are further more symptoms and signs, right? Crackles are there, and you will have S3 S3 gallop, S3 sound. There are usually two sounds in the heart, S1 and S2, but in the heart failure cases, S3 sound will be appeared, right? S3 sound, S3 gallop will be appeared, correct? So and then you will have orthopnea. Orthopnea is something very different. you might have heard of orthopnea. This is like when when usually we sleep on one pillow or without pillow, right? When the patient has heart failure symptoms, orthopnea, patient may need to raise their bed from the back side, from the shoulder side. They cannot lie down straight, otherwise they will have the problems. So they used to keep pillows in their head, like below their head, one pillow, two pillow, three pillow. So based on that grade also, as I was telling about the jugular vein pressure, orthopnea is also counted in the same way, like 10 centimeter up head, 30-degree or 60-degree or 90-degree. So 90-degree based on the pillow size, or based on the pillows, how much thick is the pillow, 10 centimeter, 20 centimeter, 30 centimeter, or 40 centimeter. So but these are the minor criteria, these are the minor sign and symptoms. But when you have to confirm the diagnosis, you have to take at least one major or one typical sign or symptom, and then you have to take two minor symptoms or signs. Okay, this is the criteria to define the heart failure or to confirm the heart failure: at least one major symptom or sign and two minor symptom or signs of heart failure. Correct. So this is done for heart failure with reduced ejection fraction, that is also known as HFrEF, HFrEF, HFrEF we usually call it, right? Then next is heart failure with mid-range ejection fraction. So what is heart failure with mid-range ejection fraction? That's, they have defined it as a gray area, 40 to 49% of ejection fraction. In that case, symptoms and signs may not work completely. You will get the sign and symptoms, but you need to check, you need to confirm it if it is the heart failure or not. In the heart failure with reduced ejection fraction, you need not to check because it is confirmed your ejection fraction is less and the patient is having symptoms. But here, along with the symptoms and signs, you have to check the biomarker if your biomarker is elevated. So guys, the only important biomarker for heart failure, only most widely used heart failure biomarker is NT-proBNP, natriuretic terminal T pro brain natriuretic peptide, anti pro BNP, right? Brain natriuretic peptide. So I hope you got it. The anti-proBNP is the only widely used. There are other biomarkers as well, like pro-BNP, like sorry BNP, and ST2. There are many other biomarkers, but widely used and most significant, is anti-proBNP. Remember this. And then we check out for any relevant structural heart disease. Along with the criteria, along with the signs and symptoms, we go for elevated biomarker anti-proBNP. Along with that, we will check for any structural heart disease like LVH or LAE. What is LVH? LVH is nothing but left ventricular hypertrophy, right? So your left ventricle, wall of the left ventricle will be thickened, or it will be thickened, or wall will be more than the size, actually. So that's why it will decrease the amount of the blood or volume of the left ventricular. Correct? Got it, guys? And LAE is nothing but left atrial enlargement. Okay, left atrial enlargement means what? When the left atrial enlargement is there, amount of blood which is coming from the backside to atrium, like from the lungs, it will be more, but our ventricle is not able to control or hold that much blood, and will not able to pump that much blood. So in that case, patient will get congestion. Patient will get pulmonary congestion because blood will be staying there for the seconds or more than the actual time. It will be staying in the pulmonary veins, or pulmonary veins, of course, when it is coming from the lungs to heart. So that time it will cause congestion, right, guys? So you got it. Then with the heart failure with preserved ejection fraction, where ejection fraction is more than 50%, where ejection fraction is more than 50%, again, because here ejection fraction is normal, we cannot say, based on ejection fraction, we cannot say if the patient is in heart failure. So what we'll do, we will check sign and symptoms, one major, two minor, then we will go to additional criteria, we will go to biomarker. So the story of biomarker here is totally different. I think I should not tell you because it will be more confusing, because anti-proBNP is having a normal cutoff value, that is 150 picogram per ml. right? 150 pg per ml for the heart failure. If it is more than 150 picogram per ml, it will be elevated. It will be counted as elevated, and the patient will be counted in the heart failure side, or patient will be diagnosed as a heart failure. But what is the story? NT-proBNP changes with the comorbidities, and age. In the elderly, the cutoff is 900. Elderly means more than 80 years, cutoff is 900. In the severe kidney problems or chronic kidney conditions, NT-proBNP will be high, right? Not only in heart failure, even the kidney problems will elevate the NT-proBNP. So we have to take care of those things also. While measuring the NT-proBNP, we have to take care of comorbidities also. If the patient is more aged, or patient is elderly, geriatric in the geriatric age, or if the patient is having any kidney problems, acute or chronic kidney failure. So we have to take care of those things while checking out the NT-proBNP. So if you rule out NT-proBNP, then we have to check in echocardiogram, again LVH and LAE, for any relevant structural heart disease like left ventricular hypertrophy or left atrial enlargement. Now there is another class which is based on the symptoms, and that is New York Heart Association functional class. So this NYHA class is for the functional classes, for the health related quality of life. It is not exactly quality of life, but it is the functional class, how the patient is performing their patient is performing his or her activities. So we classify the heart failure based on that. But NYHA class is used in many other conditions like myocardial infarction, in other heart attack, or in other cardiac conditions also. NYHA class can be used. But in heart failure, how we use? According to New York Heart Association, if the patient is having no limitation for the physical activity, patient he or she can do their daily activities without any restrictions, without any limitations, but they have the heart failure by echo or by biomarker NT-proBNP. So in that case, the patient will be in NYHA class 1. NYHA class 1 when patient is having no limitations for physical activity. But patient is confirmed with heart failure but have slight limitations. Symptoms are occurring on or at ordinary activities, but it goes on the rest. Patient is feeling comfortable at the rest, right? So slight limitations, comfortable at rest, symptoms are occurring at the ordinary activities. So this is condition, NYHA class 2, NYHA functional class 2. But when the patient is having remarkable limitations, like patient is not able to walk much, able to walk 100 meters, or when they are doing any heavy work, they are not able to do that heavy work, they are feeling uncomfortable, they are feeling breathlessness, or they are the symptoms are appearing on the work, on even on the routine activities like taking bath, or preparing food, or going for walk, or climbing stairs. If the patient is getting symptoms in on their routine activities, but these are uh, you know uh, correcting at the, or these are going on the comfort, going, or a patient is feeling comfortable at the rest, so that is NYHA class 3. But when the patient is unable to do completely, he has give up or she has give up, like now we cannot do the routine activities as well, and symptoms are appearing even at the rest, in that case your functional class will be NYHA class 4, and it shows the patient is too much serious and he needs the urgent medications or urgent consultation to the heart failure specialist or physician. Okay, what are the etiologies of heart failure? There are many etiologies, maybe toxic conditions, or toxic drugs, or some other drugs, or maybe climate conditions, lifestyle, and uh, pathophysiologically there are myocardial damage. Myocardium is what? It is, myocardium is the inside wall or inside layer of the wall of heart is myocardium, right? So this myocardium damage happens because of maybe ischemic heart disease or myocardial infarction, right? Due to plaque formation inside the vessels, inside the arteries. So for the myocardial damage, ischemic heart disease are responsible. Toxic damage, or maybe immune mediated inflammatory damage like endocarditis, right? Endocarditis is another reason for heart failure. Then maybe metabolic derangements. Metabolic derangements means what? The accumulation of fats, accumulation of other calcium things and all, calcium plaques and all. It will again damage the myocardium, right? So in that case, that is also responsible for heart failure. Then there are some genetic abnormalities, genetic genes which are responsible for cardiomyopathies. Genetic abnormalities like BEB genes, or there are CAPS genes, or there are many genes which are responsible for different cardiomyopathies. There are many types of cardiomyopathies. So different genes are responsible for these uh, myocardial damage kind of things. And myocardial damage is the etiology of heart failure. Next is abnormal loading conditions. Abnormal loading conditions means when the patient is normal, the loading condition means, what is the loading condition? The flow of the blood or receiving of the blood. The condition where the patient's left ventricle or right ventricle receives the blood from atriums. So that is loading condition. So when it defects, or when it goes abnormal, these things in abnormal loading conditions, the factors are like hypertension. In hypertension cases, flow will be either too much or either low. It will not be normal at all. In case of hypertension, peripheral resistance will be increased, so flow will be definitely high. And the loading conditions, the afterload and preload will be changed. Afterload will be high, or higher than the normal level, right? Then valve or myocardial structural defects. Definitely, if the patient is having any myocardium or valve structural disease, as I was telling in last class, structural diseases like mitral valve or regurgitation, or stenosis or anything. In that case, what will happen if the valves are not working properly? Then amount of the blood which is received by the left ventricle or right ventricle will not be same every time. It will be less or high. Sometimes it will be there will be no backflow restriction, right? So in that case, again, there will be abnormal loading conditions. Then pericardial and endocardial myocardial pathologies. So it is like structural heart disease from the birth. Then there are some volume overloaded. Volume overloaded are what? Maybe due to the kidney problems, maybe due to the liver problems, maybe due to the liver cirrhosis. Liver cirrhosis and kidney failure are the major reasons for heart failure, because in that case your volume overload will be there in your body. Your volume, your fluid will not go out. Fluid will not be eliminated completely, or whatever it is needed in a sufficient way. So that will cause the volume overload condition, right? Then here we can see the third thing is arrhythmias. Arrhythmias are another major factor for heart failure. Why? Tachyarrhythmias and bradyarrhythmias both. Tachyarrhythmias means when your heart rate is more than the normal, maybe 100, 200, 150, it will be more than 100. So these arrhythmias are generated from atrial and ventricle, atrium and ventricular both. That's why they have divided into atrial arrhythmias or ventricular arrhythmias. So what happens in case of atrial arrhythmias? When the atrial impulses comes out from the SA node, your systole and diastole, your systole and diastole means pumping, I mean the excitement, or the relaxation. Correct. The excitement and relaxation will be imbalanced. At that time, it will be disturbed. In the simple language, I'm telling, it will be disturbed. Otherwise, it is like afterload, preload will be disturbed completely in the atrium or in the ventricular both. In the bradycardia, again, there will be many conduction disorders which may affect the Purkinje's fiber, which may affect the other uh, bundle branches. So based on that, if it is left bundle branch, your conduction will be less, or conduction will be disturbed to your valve. And then if the conduction is disturbed, means definitely pumping capacity will be abnormal. We don't know when it will pump out and how much it will pump out. Based on the arrhythmias, we define the heart failure as well, right? So as we can see in this chart, there are many pathogenesis of heart failure that we are going to read in the next slides as well. And there are many etiologies like a RAS system, sympathetic activation, obesity, insulin resistance, and diabetes again, hyperglycemia, and inflammatory problems as well, right? So these are the problems, or these are the etiologies which causes the heart failure. Now, what are the risk factors? Or again, we can say the already having disease or comorbidities which can cause heart failure. First is coronary artery disease, hypertension, valvular heart disease, infections again, there's endocarditis, myocarditis. So it will cause the myocardium problems. It will affect the conduction system, or it will thicken the valve. So the ultimately the functional capacity will come down. And then heart failure caused by chemotherapy is another risk factor for heart failure, because chemo drugs are directly affecting your myocardium, directly affecting your pumping capacity. These are decreasing, right? And many toxic drugs are there which can change the pathophysiology or pathology of your myocardium, correct? And then increased heart rate, heart failure, yes, that is arrhythmias. And then heart failure develops through unknown causes. Of course there are unknown causes as well. So what are the different things, other parts, other risk factors? Sedentary lifestyle is many things. Obese women have a 50% greater risk of heart failure than women of normal weight. Guys listening, obese women have a 50% of greater risk of heart failure than women of normal weight. Got it. Then excess amount of sodium and fluid can lead to fluid buildup in the organs and tissue, causing swellings. In that case also, your heart failure will be, there are the high chances to develop heart failure, because in that case, your kidney will not be able to remove, or will not be able to reabsorb all the amount of sodium and fluid. It will not be able to eliminate everything, right? And we should limit our fluid intake as well. If you have any symptoms, I'm telling you guys, if you have any symptoms, you should limit your sodium amount and limit your water intake or fluid intake as well. And alcohol and drug abuses are another risk factor for heart failure. Okay, so pathophysiology, if I tell you, it is quite simple, because we already discussed this in our past classes in ACE inhibitors and ARBs. So when your output is reduced, if we can see the first line, blue color line, if your cardiac output is reduced, what happens? Your in the kidney, RAA, renin angiotensin system will activate, right? Renin aldosterone angiotensin system will be activated due to the low renal perfusion, because cardiac output is reduced, so renal perfusion will be less. Renal perfusion is what, the absorption and all everything which is done by the nephrons, it will be reduced, right? When it is reduced, the renal perfusion is reduced, and then RAS system is RAS is activated. What will happen? Renin will be released, and it will go to lungs, as we have read in ACE inhibitors. And in lungs, angiotensin will convert into angiotensin 1, right? Sorry, in the kidney only, angiotensinogen will convert into angiotensin 1, and in lungs, angiotensin 1 will convert into angiotensin 2 by angiotensin converting enzyme in lungs, right? Now it will go to the different parts of the body, different vital organs like liver or kidney, or your lungs itself, or the adrenal gland, right? In adrenal gland, it will initiate secreting aldosterone. In pituitary glands, it will start secreting antidiuretic hormone, ADH. So ultimately what they will do, they are responsible for the sodium and fluid retention, and causing myocardial fibrosis, right? So if the sodium fluid retention is initiated once, or it is imbalanced, or sodium fluid retention is happening, then what will happen? Your cardiac output, your cardiac load, afterload will increase, because there is the larger number of fluid in the body. So definitely your heart pumping capacity will decrease, and it will develop heart failure, right? In the another side, your carotid baroreceptor responses will activate your sympathetic nervous system. Sympathetic nervous system. In that case, your heart rate will increase, or your positive, effect on myocardial contraction. It will show the positive effect on myocardial contraction, and then it will be showing the increased in BP and increased in your heart rate. And then again, what will happen after this fluid retention, myocardial fibrosis or vasoconstriction? What will happen? Negative remodeling of heart. Negative remodeling of heart means what? Negative remodeling means whatever is the function of the heart or ventricles, it will be going down, or it will be going opposite, or it will be working as that the cells of myocardium will alter, will start changing, and will alter the function of, they will alter their functions as well, right? And then it will worsen, the left ventricle function, right guys? So these two are the major pathological pathophysiological pathways of heart failure. Correct. So how to diagnose the heart failure? Now next thing is how to diagnose the heart failure if you get any heart failure patients. Okay, in your wards, in your maybe in the clinics or in your emergency, if you get a patient suspected to heart failure, what would be the suspicion? The patient will be having dyspnea, patient will be having fatigue, patient will be having edema or orthopnea, as I was telling, and he's showing a PND as well, paroxysmal nocturnal dyspnea. So you will check one major, two minor symptoms or signs, right? Then you will seek for the evidences for underlying heart diseases. You will see if the heart failure is genuine or the primary, or it is caused by something else like hypertensive heart disease, or maybe myocardial infarction, or maybe infections, or maybe due to your arrhythmias. So you will check for all the underlying causes. Correct. After underlying causes, you have to confirm. You have to confirm. So you will find out the cardiac and other relevant histories. I was telling valvular heart disease, or arrhythmias, or angina, or any myocardial infarction, previous problems, previous heart attack, right? Based on that, you will go for the blood tests. Blood tests are BNP or anti-proBNP. Anti-proBNP, as I'm telling, brain natriuretic peptide is the significant biomarker for heart failure, is the only significant biomarker for heart failure, evidence based proved, evidence based, we can say the proved biomarker. Correct. And then you will go for full blood count, guys. So heart failure, you have to check everything. Heart failure, like full blood count, renal count, liver function, thyroid function, because hypertension can be caused by anything. If your heart failure, if your renal problem is there, if your patient is having renal insufficiencies, you will get in the tests. So you will get the underlying causes based on the blood test. You will get if it is due to what we say, anemia. It is maybe due to anemia, or it is maybe due to your renal insufficiency, or it is maybe due to liver cirrhosis. So for that, you have to do the thorough blood tests. You have to do the thorough blood checkup in case of if you are suspecting any patient with heart failure. Correct. And then what are the signs and symptoms or the clinical examinations you have to do? You have to check for tachyarrhythmia. You have to check for tachypnea, if the patient's respiratory rate is normal or not. You have to check for oxygen saturation. Why oxygen saturation? Because dyspnea or breathlessness is the primary symptom of heart failure. Then you have to check for jugular vein pressure. As I was telling, you have to check for the elevation of jugular venous pressure. Then you have to check for third heart sound, as I was telling, S3. Then you have to check for other murmurs or pulmonary crackles or peripheral edema. After that, what's there? How to check the imaging? Imaging, there are nothing, but you have to go for echocardiogram. Echocardiogram is very, very important. Echocardiogram will show you the functional and structural changes of the heart. Without echocardiogram, do not confirm the heart failure, because echocardiogram will only tell you the ejection fraction, will only tell you the structural and functional changes in your heart. Correct. So this is the chart which is showing how to diagnose your heart failure patients. Everything is there. Then how to manage the heart failure patient? There are two types. One is non-pharmacological, one is pharmacological and surgical. But before that, what should be the goals of heart failure patient? The major goals of heart failure management is in a patient care includes to improve the clinical status. First, we have to relieve the symptoms of the patient. First, we have to alleviate all the symptoms of the patient, like breathlessness, correct? Because patient is in trouble, or PND or peripheral edema because he is feeling uncomfortable. So first of all, we should look at the symptomatic treatment of the heart failure, because heart failure is not a disease which can be treated in 2 days or 3 days. So first of all, we need to go for symptomatic relief, correct? And then we will go for health related quality of life and functional capacity. What I was talking about is NYHA, New York Heart Association. So we have to improve the health related quality of life. If the patient is in fourth class, we have to take it down to the NYHA class first or second, where we usually need to take care. So first of all, clinical symptoms we have to relieve. Then we have to improve the health related quality of life. Then we have to prevent the frequent rehospitalizations, because heart failure is known for rehospitalizations, frequent rehospitalizations, correct? Because in heart failure patients, if it is severe, the patient will get the symptoms, and symptoms are very dangerous. In that case, patient will feel uncomfortable. He will be breathlessness, he will be restless, he will be feeling excess fatigue, or that kind of symptoms will be there. Peripheral edema, so weight will increase, right? So we have to prevent the frequent hospitalizations. We have to reduce the mortality rate, because in heart failure patients, the life is degrading day by day. you know if the patient gets heart failure once, life will degrade day by day if they are not taking medicines properly, or if they are not taking care of their fluid intake, their salt intake, their alcohol intake and everything. The life is very short, frankly. So okay, if you get the heart failure, how to manage? First is non-pharmacological management. First, we should not jump to medicines directly. We should try with fluid intake management. So there is the theory, guys. There is the theory. You should take care of that. You can use it even there. You can, if you see any heart failure patient, you can manage that accordingly. You can check out. Fluid intake theory here is like, if the patient is taking 1 liter per day, right? You have to measure per day the patient's urine output, right? Urine output. So if you have started checking by tomorrow, if the patient's urine output is 1.5 liter or 2 liters, suppose the urine output is 2 liters in a day, right? Then your fluid intake for next day should not be more than the quantity of urine output, or the urine output into 1.5, into 1.5. You cannot give more than 1.5 times more. If the patient's urine output is 2 liter, next day's total fluid intake will be 3 liter. If today's patient's urine output is 1 liter, the next day's total fluid intake will be 1.5 liter. Got my point? So in that case, why? Because fluid intake will increase the fluid overload in your body, and it will increase your output. It will increase the afterload, and fluid overload will cause the peripheral edema, will cause the congestion, will cause the pulmonary problems, and ultimately it will cause the symptoms of heart failure, right? So that's why we have to calculate the fluid intake on the daily basis based on the urine output, right? And the weight management is necessary. Why weight management? Because to check out the fluid overload, or to check out the fluid of course, fluid overload in the body. Then the sodium restriction. Why sodium is restricted in that? Because when your body has the fluid overload, if there is too much sodium, then it will impact on your cardiac impulses. It will impact your cardiac conduction, and the reabsorption of the sodium will be more, and it will again cause the sodium water retention. And sodium water retention is the major pathophysiology of heart failure. So if sodium is not restricted, sodium water retention will be more in the body, and it will cause the congestion again. It will increase the fluid overload, and it will cause the symptoms of heart failure. That's why sodium restriction is very important in heart failure patients. And obesity control, as we were saying, obese women, 50% of the obese women will get the higher chances to get higher chances of heart failure, right? Then the nutritional management. we should take care of the nutritional food and diet of the patient. In that case, maybe in the severe cases you need rehabilitation, right? And then maybe lifestyle modifications, maybe little bit exercises or brisk walking and all these things are helpful in the heart failure. So these are the non-pharmacological management. Then there are something called additive therapies. Additive therapies are nothing but just to alleviate the symptoms, like supplement oxygen. As you can see, this machine is a CPAP, continuous positive airway pressure. It maintains your airway pressure, or it will maintains the oxygen supply to your lungs. So the patient will not feel breathlessness or nocturnal dyspnea in that case. And then vaccinations are very important. See, additive therapies, vaccinations. Why vaccinations are important? Heart failure, because when your heart failure, pumping capacity is reduced, or ejection fraction is reduced, or the valve is, the wall of heart is, abnormal, or it is like maybe increased size, or maybe fibrosis and all. So there are the high chances of getting infections. Like influenza vaccines are important, pneumonia vaccines are, pneumonic vaccines are very important in heart failure patients. Then at the end result, end results, there are some surgical strategies like heart transplant, but that is the end result. These are very expensive and not more successful. The success rate is like less than 50% only, right? So heart transplants at the end stage, we can say the strategies, treatment strategies. Then the ventricular restoration, maybe by some other surgeries, and then cardiac support devices, ICDs, intracardiac, sorry, implantable cardioverter defibrillator. ICD is implantable cardioverter defibrillator. So it will, maintain your impulses in your left ventricle, and it will maintain the pumping capacity, ICD. Then maybe revascularization or valvular corrections in case of comorbidities. If the patient is having MI, or patient got a heart attack, in case of that, patient needs revascularization, and patient needs valvular correction if there is any valvular condition like regurgitation or stenosis or pulmonary problems. Correct. Then now let's come to the pharmacological algorithm and discuss it. So from starting, these are two classes here. One is in the yellow, it is class 2A. Class 1 is in the green color. What is class? Class is based on evidences. First we should go with the class A, and then we should go with the class 2A, evidences of the class, right? These are the classes, shows the evidences, these resource, the data or resources for these evidences are primary, and resources for these yellow treatments or yellow medicines are from the secondary resources, and resources are not well validated, right? So in that case, how it will go? Patients with symptomatic heart failure with reduced ejection fraction. If the patient is coming, as we have discussed in last classes also, ACE inhibitors are the major therapy for heart failure, as well as hypertension. So first line therapy here is ACE inhibitors, right? We should start with the lower dose, and we can up titrate up to maximum dose based on the evidence based doses. Like enalapril, minimum dose is like ramipril or enalapril, it is 1.25, maximum dose is 5 or 10 mg, like 5 for enalapril and 10 mg for ramipril in heart failure. So we can taper it just to alleviate the symptoms, or because these are also called regenerative medicines. So in that case, whatever the degeneration happened, they will revert that degeneration from the myocardium, from the walls, or from the cells. It will come to the normal, right? Then after ACE inhibitors, beta blockers can be start immediately, right? Beta blockers are increasing the perfusion of kidney, or perfusion in the valve of your heart, right? So then after that, if the patient is still symptomatic, and left ventricular ejection fraction is less than 35%, if the patient is still symptomatic, then start some mineralocorticoid receptor antagonist. What is mineralocorticoid receptor antagonist? Spironolactone, diuretics. Spironolactone, majorly spironolactone is very much effective in heart failures, right? So you can add spironolactone to ACE inhibitors or beta blockers, or ACE inhibitors and beta blockers. We can give both together. correct? If there is now improvement, no symptoms, then no further action required, and consider the reducing diuretic dose, or relieve the patient from the hospital. Here this line. But again, even after MR antagonist, if the patient is having symptoms, then we should check if the patient is able to tolerate ACE inhibitors or ARB. Then in that case, ACE inhibitors can be replaced by ARNI. ARNI is nothing but ARNI is nothing but it is neprylation inhibitors, right? Neprylation inhibitors. So what is ARNI drug, guys? If you must know, if you have seen in your hospitals, those drugs are nothing but sacubitril and valsartan. Combination of sacubitril and valsartan. Sacubitril here is a neprylation inhibitor, and valsartan is ARB. So when ACE inhibitors or ARB is tolerable, but the patient is not, improving with the ACE inhibitors, beta blockers, and MR antagonists like spironolactone, then we have to add or replace ACE inhibitors by ARNI. And ARNI is the combination of two drugs, sacubitril plus valsartan. Okay, this is the one therapy. Then if the patient is in sinus rhythm and patient's QRS duration is more than 130 milliseconds. QRS is what? QRS is the we can say kind of length or kind of duration of that repolarization, early repolarization. If you must if you remember from the last class, in the ECG or in the repolarization phase in the myocardial repolarization curve, if you see that early repolarization is QRS, and if it goes more than if it goes than 130 milliseconds, then we need to evaluate if the patient is financially well, or if the patient is suitable for CRT. CRT is what? CRT is what, guys? Cardiac resynchronization therapy. Cardiac resynchronization therapy. So this is a kind of device which will be put under your skin on the chest, and the wires of CRT, there are wire or wireless CRTs. If wire, then the wire will be passed to your ventricles, and it will maintain your heart rhythm. It will maintain your heart rhythm, and the heart failure symptoms will come down. But if the patient is in sinus rhythm but heart rate is more than 70 beats per minute, heart rate is more than 70 beats per minute, in that case we need to control the heart rate. Means in the tachycardiac situations, we need to give ivabradine, or beta blockers are already there, then we have to replace beta blockers with ivabradine. Ivabradine is importantly or majorly just to reduce the heart rate. Okay, guys. So yeah, so in that case, I'm so sorry, why is happening? Okay, then if it is not happening, then we consider the inotropes, or like LVAD or heart failure transplant, or maybe diuretics we can add on, or based on the congestion symptoms we can increase those things, or we can go for the ICD. ICD is nothing but implantable cardioverter defibrillator, so which will again help in the conduction system of heart. So this is the ICD, guys. This is the ICD. If you can see, ICD is under your skin on the chest, and the wires will go to your right atrium and right ventricle, and it will generate the impulse, or it will control your original impulses or original cardiac, mm, uh, you know, uh, what we say, the electrical system. Correct? Okay, then what are the comorbidities of heart failure? First of all, comorbidities of heart failure can interfere with the diagnostic procedures. Like if the patient is having COPD, there will be very much difficulty in diagnosis of heart failure, because COPD and heart failure both have the similar symptoms: breathlessness, crackling, respiratory crackling. Both have the similar symptoms. So COPD and heart failure are always misdiagnosed to each other, right? So that's why interference with the diagnosis. Burden of the hospitalization and mortality will increase. If the patient is heart attack, or patient is with the hypertension or diabetes, then the burden of hospitalization will be increased along with hypertension. Then comorbidities can increase the heart failure symptoms. Comorbidities can worsen the quality of life. These can affect the treatment of heart failure. These can, there will be, might be interaction between 2 drugs or 3 drugs in case you have the comorbidities. So what are the comorbidities? As we were discussing, like coronary artery disease, heart failure, hypertension, diabetes, anemia, hypokalemia or hyperkalemia, because in heart failure we give diuretics. So these things are very, very common, hyperkalemia or hypokalemia. Then maybe central nervous system problems, kidney functions, maybe cancer. Cancer drugs can cause heart failure. Lung diseases like COPD, asthma, sleep disturbances, obesity, valvular heart disease. These are the comorbidities of heart failure. Then what is the magnitude of heart failure? We are discussing heart failure for almost last 1 hour. Now, what is the magnitude? Why we are discussing actually heart failure? So burden of heart failure in India is approximately 2 to 5 million patients with an estimate prevalence of 2 to 3 per thousand population, right? This is the approximate burden of heart failure in India. Heart failure is responsible for 1.8 million admissions annually in India. 1.8 million admissions annually in India. Okay. And the most important part is Indian heart failure patients are younger. In India, patients are developing the heart failure in younger age. At average, it is like 53 years against 69 years in US and Europe. Where in US and Europe, patients are like average age of heart failure patient is 69 years. In India, it is just 53 years, all around 16 years less. So we should be worried. In hospital mortality, like when the patient is admitted for heart failure, there are the chances of death, there are the chances of mortality. So in India, it is 10 to 30%. In US and Europe, it is just 4 to 7%. Reasons could be anything, but these are just the statistics magnitude of the heart failure problem, right? 10 to 30% versus 4 to 7% in US and Europe. Then the prevalence of heart failure is escalating even after optimal management policies, right? So the current burden of heart failure is 3% worldwide. It is 3% worldwide, right, guys? So this is the one simple table. If I say the simple table is around, which is showing the difference between India or Asian and other US and European studies. So sorry, I think my questions are coming now. Okay, I will just remove these names. Okay, so as we can see, this study here in the first row, or second column, MHFR, if you can see here, MHFR is done by me. It is going on. It is still going on. These results are from 2019 when we have done this study like for 3 years. That time we came to know that our study is doing well, and we have around our median age of patients is 64.5. Almost 65 years. Where in US and Europe it is 60, in 69 or 70. In our study also it was around 65 years. This study is done by BMHFR, Manipal Heart Failure Registry. Okay, and then the proportion of females was really high. In our patient, it was 41%. In other Indian registry, this is Trivandrum Heart Failure Registry, is 31. In other studies, if we can see, it is more than 50% or around 50%. If we come to the etiology, in our cases, ischemic heart disease was around 40%, but in others it was varied. But like if we see in the Asian Adair, it is 57% ischemic heart disease etiology, and in European it is 30% or 46%. So it was almost similar. Then non-ischemic cardiomyopathy is 24.2% in our studies, but in many studies they did not consider non-ischemic cardiomyopathy as a etiology, right? When we come to the comorbidities, hypertension as a comorbidity was found in 51%, diabetes in 42% of the patient, and anemia. Guys, anemia is the major comorbidity of heart failure. I'm telling, this is 43% in our study, and other studies they did not consider anemia as a comorbidity of hypertension or comorbidity of heart failure. But heart failure patients are more prone to get anemia. Their hemoglobin will be decreased, right? So we have to take care of their nutritional diets, or nutritional management is very, very important in case of anemia and heart failure. Okay, so then I hope this is done from my side for today. Now let's discuss the questions, guys. Okay, so my first question is, You all can answer here in the Zoom or maybe in the YouTube, guys. What are the typical symptoms of heart failure? Except, like there are the five we have, I have kept here. Like one is fatigue, dyspnea, pedal edema, angioedema, paroxysmal nocturnal dyspnea. So you can tell me what is the heart failure symptoms? What are the heart failure symptoms? Except which one is not the heart failure symptom exactly in this list? So tell me, guys.
Angioedema.
You can write. So I think you should not tell. You are not supposed to tell. You have to write. Five. No, people, no, 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 not five. It is four. Angioedema is not at all a symptom of heart failure. Angioedema is not at all a heart failure symptom. Correct, guys? So this is angioedema, right? And then this is a quite typical question for you guys. Quite typical. So you tell me, what is the answer of this question? Correct phenomenon for systolic dysfunction is what? Low ejection fraction and lesser amount of blood is pumped out of left ventricle, or low ejection fraction and normal amount of blood is pumped out of left ventricular, or normal ejection fraction and lesser amount of blood is pumped out of left ventricular, normal ejection fraction and normal amount of blood is pumped out of left ventricular. So guys, you have to tell me now what is the correct answer. Okay, by the way, it is wrong, Harsha. Yes, guys. Question number B, ka, what is the answer? Okay. Okay, people are going right. Yes, so answer is 1. Question number B, answer is 1. In the systolic dysfunction, ejection fraction will be low and the pumping capacity will be low. So lesser amount of blood is pumped out of the left ventricular, right? Why it is? Because see, if you read other phenomenon, low ejection fraction and normal amount of the blood. Systolic dysfunction will not, normal amount of blood will not be pumped in any case. Correct. Normal amount of blood will not be pumped in any case. So, and in systolic dysfunction means normal ejection fraction will not be there. So all three are dismissed. Only one, number one is correct answer. Number one is the correct answer. Okay, guys. Okay, so let's go to the next question. Heart failure with preserved ejection fraction shows. Which is the ejection fraction, correct ejection fraction for heart failure with preserved ejection fraction, guys? Okay, correct. So for question C, what is the right answer, guys? Okay, tell me, guys. Yes, correct. Question number C, 3. Yes, yes, it is 3. Ejection fraction is normal here. In heart failure with preserved ejection fraction will be more than 50. Right, guys? Got it? Then, now, which one or which NYHA class represents that statement? Remarkable limitations, symptoms at routine activities, comfortable at rest. So which NYHA class represents the statement? Okay, okay, okay. Yes, guys. No. Okay, so here answer again is 3. NYHA 3 is the remarkable limitations, symptoms at routine activities, comfortable at rest. NYHA 3. Okay. So what is the next answer? What is the next question? I'm so sorry. Yeah. Biomarker to confirm the diagnosis of heart failure. I think this is the easiest. This is the easiest question for all of you guys. Yes. Biomarker to diagnose the heart failure, to confirm the heart failure? Yes, guys. NT-proBNP. You must know NT-proBNP is the only biomarker which confirms the heart failure, like widely used or majorly used, right? NT-proBNP. Okay, guys. So let's go to the question number E. I think today I got a few more questions. Okay, so ICD stands for what? Implantable cardiac defibrillator, implantable cardioverter degenerator, implanted cardiac defibrillator, or implantable cardioverter defibrillator. What is exactly the full form of ICD? ICD's full form. Guys, tell me the ICD's full form. Yes. Yes. Wrong. Many are wrong. Many are wrong. Many are wrong. So the correct answer is 4. Implantable cardioverter defibrillator. Implantable cardioverter defibrillator. Answer is 4. Implantable cardioverter defibrillator, because it is converting exactly the abnormal heart rate or abnormal rhythms, abnormal impulses, right? So this is implantable cardioverter defibrillator. Okay, guys, got it? So yeah, let's go to the next question if we have. No, we do not have any more questions. Thank you very much, guys. Now I will take your questions. If you have any questions, we will take from the chat box, or we will take from the YouTube. Do you have any question, guys? Okay, let me check above. Oh no, I think I cannot see all the comments. If you have any questions, please type again, guys. I will answer all the questions. Okay, Marine is asking, what would be the ideal time to check the BP of a normal person? Will these be any variations in BP regarding before and after taking food? No, I think food does not matter much, but of course, rest is, rest matters. When the patient is coming to your clinic by walking or after walking, you should take care of that. Uh, and you should let him wait for 5 minutes. You should take him, you should let him take rest for 5 minutes. Then only you should go for BP checkup. You should not directly check in the BP once the patient is coming from walk. Okay. How prevalent is increased heart rate failure, and what is the treatment for the same? As I was telling, increased heart rate is the prevalence of increased heart rate is not that much, but of course it is around 5 to 10% of heart failures. And in that case, we treat the patients with beta blockers or ivermectin, because these are the two categories of the drugs to control the heart rate. NC Joseph, I hope your question is clear. Yes. Okay. So next is, what would be the, okay, idle time done. Can you please tell us about the role of other biomarkers, sir? See, role of other biomarkers, if I tell you, in heart failure is not much, because NT-proBNP is the only validated biomarker for heart failure. But of course, as troponin T is very much important for myocardial infarction, and even CKMB, and there are further biomarkers. ST2 is for degenerative problems. ST2 we check, correct? And biomarkers are to confirm the diagnosis. What is the importance, you are asking? The role of biomarkers, we have to confirm the diagnosis, because based on the sign and symptoms we cannot diagnose any disease. As COPD and heart failure, these both have the similar symptoms, similar sign and symptoms, right? So we always misdiagnose. Most of the patients are misdiagnosed with heart failure or COPD patients are misdiagnosed with heart failure. They are on the heart failure medicines or something. So that's why we need biomarkers. Biomarkers are giving us the clear picture of the diagnosis. No, of course, digoxin has the role in heart failure management. Digoxin is the negative and positive, both negative inotrope and positive inotrope, both effect has. Digoxin is important in the symptoms relief in case of chronic hypertension, chronic heart failure. See, this class is just for 1 hour. We did not, we cannot dig into so many things. So that's why I did not include all the therapeutic aspects of heart failure. Definitely in advanced course, we will come up with all the drugs and everything about the heart failure. But it was just a basic. So yes, of course, digoxin is very important drug in heart failure. Tabian, yes. The minor symptoms you explained are actually indicating severe heart failure. So what? So are they major ones or called minor? See why they are called minor, because they are coming in very less patients. Minor means the prevalence of the symptom is less, not the intensity. The symptom could, represent the severe heart failure, but these are not appearing in all the patients, right? So why we are calling major and minor? Because breathlessness is almost appeared in 100% patients, pedal edema is almost appeared in 70% patients, and crackles are appearing almost in 50 to 60% patients, and jugular vein pressure is appearing in most of the patients. That's why we call them major symptoms or signs. But minor symptoms and signs, maybe these are associated with severity of heart failure, but the percentage in the patients, or we can say the prevalence is less. That's why we kept in the minor. Vahiba, again your question is, what is the role of chocolate for high hypertension? Okay, so I think you will get it. Troponin biomarkers which indicates okay, troponin biomarkers are for heart attack. Heart attack means myocardial infarctions. What is trop T? Trop I is an trop I is also for the heart attacks, but the sensitivity of trop I is quite lesser than trop T. What is the treatment for pregnancy induced heart failure? There are different things, there are different protocols for we cannot give all the drugs together. So in that case, in pregnancy we have to take care of the fetus also. So in that case, sometimes we go with the inotropes, or sometimes we go with the diuretics, but in the very low dose or very much monitored dose. Every in the pregnant woman we have to monitor the patients every day, or we can say with the every dose. Just okay, NC is asking, just EF is the parameter into echo to diagnose heart failure. What is the role of TEPC and other parameters? Of course, as I was telling, see, I just touched the basic things. I just touched the basic things like LVH or LAE or TEPC. These are very important in heart failure. But TEPC, TEPC is quite, if we say, is quite typical, or it is not that much prevalent in heart failure patients. Because we can diagnose the patient based on the ejection fraction, and if it is not if it is like systolic heart failure, or if it is like heart failure with preserved ejection fraction where ejection fraction is normal, then we can go for the structural changes. Structural changes like left ventricular hypertrophy or left atrial enlargement, and then TEPC comes at the end, not at the first, definitely. But yes, TEPC has some role in heart. TEPC has the role in heart failure as well. Okay, the cause of angioedema is ACE inhibitors, and the discontinuation of the drug is the treatment. Okay, so yeah. Explain the mechanism of action of sacubitril in heart failure. Neprylation inhibitor. There is the neprylation inhibitor, neprylation receptors in the heart, in the myocardium. So those are very much active, and those are impacting the signaling, impacting the muscular functions, the cardiovascular functions. So in that case, sacubitril bind with the neprylation receptors and block them, and then it will affect on the, then it will improve the symptoms, or improve the functionality of the myocardium cells. Okay, what are the golden markers of evaluate the progression of cardiac remodeling and degenerative changes in experiment? Sanskar Virmani, it's a fantastic question. So golden markers to evaluate the progression of cardiac remodeling is just echo. echo, not the NT-proBNP. NT-proBNP is to diagnose and is to to see the improvement of symptoms. Of course, NT-proBNP is there, but not the golden biomarker. Golden biomarkers are, as we were discussing, the TAPC and left atrial enlargement and the other cellular biomarkers. So these are very specific biomarkers like TAPC and all in echo. Remodeling can be seen, and remodeling or degenerative changes can be seen in echo only. Or maybe then we can go for sometimes CT scan, cardiothoracic scan can help in that. Like amyloidosis or fibrosis, CT will help. But those things, the biomarkers are histopathological biomarkers. Those are not exactly the blood biomarkers or something, but these can be seen in the radiogram or radiology by like echo or a CT or maybe the histological testing. Okay, Jency is asking, sir, nowadays females are equally affected with heart failure like men. What may be the reason? See, reason is first I will say obesity, sedentary lifestyle, maybe, and maybe the pregnancy-related problems, or there are many things which can affect the women as well as men. Men's are actually heart failure is seen most probably. It is like equal for men and women. It depends. Heart failure could be because of unknown reasons. Yes, there are some unknown reasons which can cause the heart failure. Maybe some genetic reasons, or maybe some your dietary factors, or maybe some there are many unknown factors which can cause heart failure. So we cannot say like heart failure is not because of unknown factors. I'm telling you, almost 17 to 20%. I know the exact figure. 17 to 20% heart failures are due to unknown reasons. Okay. Yes. Okay. So I think we are done with the questions. Do we have further questions, guys? Do we have any other question? No? Okay, then we will take off. Thank you very much. And yes, good night, guys. Take care. So this is maybe my last class, because next three classes speakers are coming. So guys, take care, and try to complete your classes for the attendance. And every registrant will get certificate if they attend all the all these exams. So you focus on exams and complete the exams. There are two exams which are done, and both are again I will open for a week, both the exams, first and second. So you have to attempt the exams, and then a final exam will be there in the end week or last week of the December. That will be open again for I think 2 or 3 days. So you all have to complete the exams. Please do it for the certificate, right? And please watch the classes for your attendance sake. Okay.